But long before the symptom begins to kick in, something else already decided whether and when one can get diagnosis, what treatment options are available to them, and whether they will survive. Distance becomes delay, delay becomes diagnosis. In many rural communities, the story starts quietly, is asking a difficult question, and we're always asking these difficult questions so that our guests can help us chew them and give us a path forward.
Whereas if we took the preventative steps that we know work well, we could actually save so many more lives, but there's no revenue for them to make if people are not sick. And that's not me being conspiracy theorist. This is the reality.
Hello and welcome. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo. Together, we are uncovering the stories, challenges, and innovations that are shaping healthcare in overlooked communities. Lung cancer remains the leading cause of cancer deaths in the United States. But long before the symptom begins to kick in, something else already decided whether and when one can get diagnosis, what treatment options are available to them, and whether they will survive. And that thing is called where you live. Distance becomes delay, delay becomes diagnosis. In many rural communities, the story starts quietly. A persistent cough maybe, a fatigue that's easily wished away, a long drive to the nearest clinic, no nearby screening sites, no specialist within reach. And by the time care is finally assessed, the disease is no longer early, it has advanced. What medical people would call metastasized, right? Unfunded health systems, limited screening infrastructure, stigma, and gaps in health literacy collides together before a patient presents themselves in the front of an oncologist. So today's episode is asking a difficult question, and we're always asking these difficult questions so that our guests can help us chew them and give us a path forward. But this question is, how do we finance lung cancer care in rural communities in ways that works for patients and not just for the system? And joining me today is someone who understands this intersection better. He's worked through science, systems work, and lived experience. So we're glad to have him in the house. But before I introduce my guest, I think we should go for a quick break. If you are listening to this conversation, don't forget to subscribe to What About Rural Health on all podcast streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are also on YouTube. Your support means a lot to us, so please like, leave a comment, share, but most importantly, drop us a review. It helps others discover this important conversation. Let me introduce you to my guests. Today we have Dr. Eugene Manley in the house. He is a cancer scientist, an equity strategist, and the founder and CEO of STEMM and Cancer Equity Foundation. He's a nationally recognized cancer equity leader whose work focuses on improving outcomes for underserved communities that have historically been left out of research, screening, treatment, or who are navigating the cancer care continuum, particularly within lung cancer. While he doesn't currently live in a rural community, his connection to rural health is deeply personal. He has spent many summers in Berkeley, West Virginia, and later returned regularly for family gatherings. And in those moments, he would witness firsthand how distance to care, limited resources, and unfunded health system would shape health experience, not just for one generation, but across families over time. Today, through his work, he has partnered with health systems people, nonprofit organizations, life science organizations to expand access to screening, biomarkers testing, and standoff care treatment and clinical trials, turning scientific progress into systems that patients can understand, use, and trust. And that is important for rural health. His work has been grounded in both his lived experience and how he himself is navigating medical racism firsthand. So, Dr. Eugene, welcome to What About Rural Health? We are so excited. I personally am excited to have you on board, looking at the fact that I'm a Black woman, right? And I live in Southside Chicago. And I have seen research that is looking at health equity and how underserved Black women but on this part, breast cancer, are struggling to access adequate and equitable health care just due to their genomic markers. So I'm so excited to have you talk from the lung cancer perspective. Welcome.
Hello, Shanasa. Thank you so much for having me on here. I think it's a pleasure to be here, and I think we're going to have a great conversation today that hopefully your audience will be able to take some tidbits that they can use as they navigate care delivery themselves.
I hope so, Dr. Eugene. Okay, so let's start that off. Before we start talking about policies and systems, I want to start, somewhere personal, as you would depict rural health can never be discussed in abstraction. So you shared, and I definitely read in your bio, that you've spent a couple of times in rural communities where you've seen these things over time, how distance and limited access is intersecting to shape family health journey. When you think back on all of this experience, what do you think rural communities are quietly paying for when lung cancer care is not adequately funded?
I think, besides spending summers in Beckley as a kid, I also did my undergrad at Michigan Tech, which is up on Lake Superior, which is also another very rural area. And the consistent thing you will see is proximity to established clinical leaders that really have expertise to treat you. Typically, you may have to go long distance, sometimes cross cities, sometimes cross states just to be treated. And then, often because you're in a rural place, there may, if you're lucky, be only one provider that can even do referrals. And then you have to navigate when you can get an appointment. And then how do you coordinate follow-up care? Like, do you have to see a medical oncologist? And those things are not typically in rural places. So the burden becomes, they keep compiling when you're trying to navigate a diagnosis. And often because you're so rural, you often don't get diagnosed until later. And then you still have to navigate how you're going to pay for these treatments. Because the thing is, the treatments are not cheap at all.
Yeah, that's true. But I kind of want you to point to an area that we don't often talk about, and that is the invisible cost of all of these things that family pay for beyond just the actual cost of care. Because when we talk about financing, people think, oh, it's all about money. And because I have a lot, I have these anecdotes. I originally come from Nigeria, and in my rural community days, as at the time that I was growing up there was really no health facility in there, right? So irrespective of the fact that, I come from a middle income economy, just growing in that environment means I don't get to even access the care, irrespective of the fact that my family could afford to pay if those care were there. So would you talk a little bit more about those kind of invisible payment costs that families get to pay because they don't have access or because care is far away?
Some of these invisible costs, health, sanity, stress, pain management, these are all things that come along, stigma, even though we talk about stigma, but stigma exists just from having a lung cancer diagnosis. And unfortunately, a lot of people assume that because someone has lung cancer, they were had a history of smoking, and while maybe 60 to 70% of lung cancer is due to a history of smoking, that is not the only risk factor. However, when we talk to people that have lung cancer, the first thing they get asked, well, oh, I'm sorry that you had lung cancer. Were you a smoker? Or people assume that they had a history of smoking, and then if they do, or whether they don't, they get treated differently than like if you had breast cancer or colon cancer or prostate. Like if you get those cancer, people will say, "Oh, I'm so sorry. How can I help you? What can we do?" But then when you get the lung cancer, they just assume, well, you just deserve to get it or you did something to make it happen. And the problem with that is when you have a diagnosis, you're already going through so much. And then how do you tell your family? Then you're worried about medical bills, medical costs. How do you keep a job? Will you lose your insurance? And then you're dealing with these societal pressures that are heaped on you through no fault of your own. And then whether or not you have a history of smoking, you then get asked. Then when you have it, and then whether or not you have a history of smoking, you still always get asked about, your smoking, and you deserve to get it. And it can wear on people. It really is wearing. And stigma is one of the biggest factors that keeps people even from getting diagnosed or even following up because you don't want to get it. But when we think factually about lung cancer, there are other risk factors for lung cancer beyond just history of smoking. Most people don't talk about radon, like indoor cooking modules, like even indoor cooking, like, when you using oil and grease and all that stuff is getting aerosolized going in the lungs. You think about firefighters, you think about people in areas with air pollution, car exhaust. So these are all other risk factors, job exposures, like working in combustible engines. These are all risk factors that aren't part of the main screening guidelines. The screening guidelines are solely predicated on someone having a history of smoking. But when you have one of these other factors, you need a facility to have included in their screening guidelines that they will include these other risk factors. And only when that is actually pushed through will a facility be able to then screen these other people.
Thank you so much for this response. I really do appreciate the angle that you brought it in. And I wanted my listeners to sit with this hidden cost idea. Because like you said, when we hear of lung cancer, it's always like pointing to one particular thing. But all of these things culminate together to shape patients' health outcome. And as a people, and I think as a community, that's something that we should have a collective concern for. But, one thing that strikes me in how lung cancer in rural communities is framed, and this is me drawing back to all that you have explaining to look at it very well in terms of framing. And you mentioned a little bit about smoking, the behavior and then the stigma that you talked about. But, from how we see it, I want you to, in this bucket of framing, talk a little bit more of what we are actually missing when we frame just this about a personal responsibility, a personal fault, because you smoke. That is why, there are a lot of people who have smoked all their life and never got lung cancer as well, right? So, can you talk a little bit about how we can either shift mindset around this framing to make it encompassing in ways that improve health outcome for people who are struggling with lung cancer?
I think you raised a very great point that we have people that have long-term had a history of smoking and never get lung cancer. We have what a lot of people don't realize. There's a large disparity in Asian females who, with no history of smoking, they have lung cancer at some high rates as well. I think maybe the rates might be right behind radon. We still don't know why. There are some groups that are trying to do lung cancer screening in Asian females to understand what is making them susceptible. And these come from different ethnicities. That's across the board. We're just seeing higher lung cancer rates. No one knows why. And so it makes a conundrum because, we have this smoking as the leading cause, but then we have these other factors at play, and we don't even have answers. But if we project this, we're going to look and see things like vaping, which is prevalent now in a lot of places. It is right now not a risk factor, but I promise you, give it about 5 to 10 years, and we will start seeing a lot more people with lung cancer due to vaping. And there's so many more chemicals in those vape cartridges. And some of these things were meant to be ingested, not inhaled. And so we don't even know all of the products. They don't always list them. So that's going to be it's going to shift the age, and it's going to shift the age phenomenally well, not that's not phenomenal, scaringly shift the age of diagnosis to earlier.
Yeah, I think I've heard that argument a lot. But, the last point you make draw me to my next question to ask you from a policy point of view. And I know we are talking mostly about financing, but we've seen that financing and decision making are around where we cap things are all interrelated, right? How, from where you sit as a leader in this space, how are all of these things culminating together to show up how policy is framing things and how those framing are structuring how guidelines are designed or developed around screening infrastructure, reimbursements, research access, and not just something about, the patient didn't just have the choice to be there.
This is an interesting question. So when we think about, there's this link between finance and policy.
Yes.
Now, on a policy lens, we've been advocating for lung cancer screening and getting coverage that to be covered by medical providers. And I think, if my memory is correct, it is technically now billable by CMS. It is billable by CMS. Just not everyone knows that it can be billed. And then when you get past that, you think about financing just in general. Last year, I believe the DoD, they have a lung cancer research program. And unfortunately, in the last budget, all the funding for lung cancer was cut. So this is all the funding for lung cancer research that would help diverse and underserved communities. And what that means is that there's a whole batch of money that's now not going to go to do studies. And people would go to DoD funding because sometimes getting the NIH funding was so hard or cumbersome. So DoD used to have set maybe 5% of their budget for medical research. I think several other cancers got their budgets cut, but lung cancer got all their budget cut. And there's a lot of stuff that sometimes impacted veterans, it impacted rural. And you don't necessarily control the levers of policy and finance. And sometimes in this case, they overlap. And so when this happens, that means understanding the disease, understanding how to treat it, how to get more access is gone. And then we end up having patients that then don't get to benefit.
This is really an important point that you raise here. Thank you so much for that. I mean, I'm taking it in, and I believe that my listeners are also understanding how these two things entangle together to create, like you called it, the conundrum that we are seeing right now, where things are pushed back out from the system to the patients, right? So, and bearing this in mind, how do we then within the healthcare system now, not within the policy system, shift this question from, why won't patients show up early, to how do we fix the funding system upstream, like from the health system environment with all of these funding cuts? How do we do that so that we can be able to see the obvious and work around it? Because I know we are in a time where everything is up in the air, but systems are also restructuring within that constraint to figure out a pathway.
This is always the challenge. Where do we find the funding to then implement the programs and processes that will further go downstream? And typically the problem is the funding side doesn't necessarily always see the value of the downstream. Mm-hmm. And that's even more general. If you think about it, we do a terrible job of preventive medicine.
Yeah.
For some reason, insurers, providers, we don't want to treat people until they have a disease. Mm-hmm. And then once you have a disease, it becomes much harder to treat, or in some cases more lucrative to treat, because then you can put them on all these medications. Whereas if we took the preventative steps that we know work well, we could actually save so many more lives, but there's no revenue for them to make if people are not sick. And this is not me being conspiracy theorist. This is the reality.
That is true. many of my guests have made this point clearly. So thank you for raising that point. So to my listener, it is important to properly frame lung cancer in rural community, because doing so help us see it as more than just a medical issue. It pushes us to interrogate the policy choices, the investment decision, and the system level determinants that shape cancer care. But as you listen, I would want you to have reflections on what we are discussing. And please pause, reflect, and connect with this conversation to your own community. Whatever comes out of your mind, please feel free to add in the comment section. Let's hear your opinion regarding this. But the guided question will be, when you think about lung cancer in your community, what barriers will you classify as medical? And which one do you think are a result of policy or funding decision? And if rural communities have more choice, including your community, on how cancer care is funded and delivered, what do you think you want to change first? Is it access, improving access, or increasing community trust, or just focus on looking at patients' outcome? All right. We are back to you, Dr. Eugene. From your work across cancer research and equity, where do you see the biggest financing gap in rural lung cancer care? Places where, go ahead.
I think the biggest gap is part financing, but it's related to lung cancer screening. Because we know that we have a high rural population that has lung cancer. Often they're in areas that have radon, like Kentucky. They're areas that, have worked in coal, like West Virginia. I think even part to a degree Utah. But the problem is we have these screening facilities typically at major medical centers, major national comprehensive cancer centers. They usually are clustered in the Northeast and out west. But the areas that also have high rates, like basically going, let's say, Montana, diagonally down, going to the Southeast, we don't have as many facilities at all for the number of people that need screening. So conceptually, what this means, the people who need to be screened can't even get to a facility. And that means you don't detect it early. Then by the time they have these symptoms, which, as you correctly said, are often a cough or hidden pain, and often is misdiagnosed, they end up with much worse disease. If we could put more facilities in those rural areas and reduce that distance to travel, we could significantly make a difference for these patients.
Thank you for your response. And I want to follow up to ask you, why? Why do you think lung cancer in particular remains so underfunded compared to other cancers?
This is a very good question. And we all ask this ourselves in the lung cancer space, because we know that lung cancer is the leading cause of cancer death in the U.S. and worldwide. Yet lung cancer receives much, much less funding than breast, colon, and prostate. Yeah. And when patients have those cancers, there's a lot stronger advocacy, a lot more empathy, a lot more programs. But for some reason, lung cancer is just, you got it. You deserve it to get it, and you shouldn't be acknowledged. But the problem is, as a field, lung cancer has driven a lot of precision medicine in the last 20 plus years. The first biomarker in lung cancer was epidermal growth factor receptor. That was discovered around 2003-ish. Since then, they now have about 10 to 11 biomarkers for lung cancer. Some of these are immunotherapy markers. And then there's different variants of some of these therapies, even within a gene target. But if it wasn't for lung cancer discovering these, we wouldn't have therapies that now are also being used for some other diseases. So that's why it's always so, to some of us, frustrating and disheartening to see that lung cancer doesn't get the funding it receives for the population that it is treating. But I think if you think about it, there were these very, very strong anti-smoking campaigns in the 80s that had such graphic imagery. And on the one hand, yes, it would make people want to quit having a history of smoking. It also then maybe made the communities and people think, well, God, if you did that, you deserve to be in a condition here, so we're not going to care for you. And whether you smoke or not, or have a history of smoking, should not determine whether you should get treatment. You should still be treated the same no matter what.
Thank you so much for your response. And sincerely, I want to slow this a little bit down because I understand from my own little research that lung cancer care is extremely expensive, right? And when we look at the screening, especially in rural communities, and you've established the fact that the particular communities, the areas that need them most, have less screening facilities, right? Biomarker testings and NGS testing are costly, and reimbursement is uneven. We don't even still know yet how the health insurance people are navigating these reimbursement processes when it comes to testing. Clinical trials are concentrated in the urban. You've established that. I'm just trying to make sure that I slow it down for my audience to understand where we are at with things. And most of these trials are in academic centers who are trying to use precision science to get to the top of the top. What that means is that sometimes selection processes are also uneven on who gets into the trial and who doesn't, right? And within all of these things, navigation gap between rural and urban makes it impossible for patients to stay on course, to come to appointment when they are needed. Sometimes they delay care, and then the drop-off rate for trials are higher for those who are participating from rural communities. Couple that with financing, which is always very difficult, but also the fact that we are not paying attention to the actual process of coordinating care and building trust. So having reeled all of this down, I just wanted us to slow down and get to what the crux of the conversation is. How do we then build the trust of rural communities, rural health systems that is already fragile, when all of this is happening? Because I am asking this, for rural environment, trust is very, very key to how they perceive and receive care. So how do we navigate all of these things to make sure that, we get the adequate care that rural community needs closer to them?
I think this is just me making some ideals because I don't even know if it's been done. You would like to see people from your community that are helping provide the care because they kind of understand how people work and operate in those areas. I just thought, I don't know if it's been being done, and I probably should know this. Maybe you can get a provider from a major medical center to come to some of these rural areas maybe once a month or every other month. It depends on licensing, I believe. But if you could get that and at least get a person there that could do some of the initial workup, but then you're still coordinating, diagnostic facilities, tissue testing facilities. And I think just more empathy and understanding, and because some of the issues that rural communities face are the same things that inner city communities face. Just they don't feel seen, they don't feel listened to, they don't feel respected. They often, they have major fear of getting the disease, and then sometimes it's a crippling and paralyzing fear for trying to navigate it.
Yeah.
And the other challenge is maybe more pressing. You don't have a lot of navigators out there. And when you don't have those navigators, they are the bridge between often the clinician or the surgeon and the patient, and they help explain you the whole process of what you should be going through, and they can help get you resources. So this is the whole kind of breakdown that we have when we don't have people in these places.
I absolutely agree with you. And I think I do have my last guest who was kind of like rolling out funding mechanism that gets to community and talked about the community model. I'm a student of ABCD, participatory process, community-led, centered approach. But one thing that often come back as critic for most of these things. And I mean, it's in both ways. The advantage of community-led initiative is that you have to transfer skills that resides within the community, at least to the point where those upskilled people remained in that community, right? But other conversation is if communities are totally leading approaches themselves, then they all only know what they know. And if you remember my anecdotes, I don't know what to ask if I've never seen it before. So I like the fact that this is not like a question. This is me kind of like brainstorming on what you just said. Like the fact that there needs to be some level of integrated care that's happening. But that integrated care needs to be led in ways that communities are at the forefront. But before I bring my next question, let's go for a very short break. Do you have a rural health stories that need to be heard? Whether you are a health worker, patient, policy maker, or advocate, we want to hear from you. Share your story on our website at www.whataboutruralhealth.com/stories and help us amplify the realities behind the data. Someone from our team will contact you with detail on how to get your story published on our newsletters, websites, and other media platforms. Welcome back. You are still listening to What About Rural Health with Chinasa, and I am with Dr. Eugene Manley Jr. So, Dr. Eugene, I think we've spent a lot of time discussing the problem and the challenges, and now I would like us to pivot to talking about financing solutions that we could potentially explore here. Some systems argue that rural cancer care is too expensive to scale equitably. How do you respond to that conversation?
Well, the first time anyone says something's too expensive to scale, that means they don't care about the patients. It doesn't matter what it costs to implement. I mean, to a degree, but you can't be afraid of cost. You have to then build in buffer and overhead to cover the cost. And then is it some kind of tax? Because they tax us for everything else. So can you put a health tax to help for lung cancer screening in communities? But this could be cancer screening in general, so you could encompass all of them, because the issues in rural health are not just for lung cancer. It is other cancers have high rates. We have comorbidities, we have sometimes sedentary lifestyles, we don't have the best diet. These are all contributing factors. So
yeah,
I was thinking that I'm just thinking, making sure I answered the question.
You did in some way, and I want to just add a little bit of follow up to what you have said. That I was reading something yesterday, a post on LinkedIn that was talking about rural communities don't really need skill. The conversation about skilling is not the right conversation. The conversation is actually about understanding what are those determinants of community health needs, being able to specifically domesticate them within the features that we see from each community, right? And that is capital intensive, right, as well. Because we can talk about scaling. What about using the word scaling and then you get on ground and there's nothing to scale? If there's no facility to scale, if there's no screening, anything to scale. So how about we not looking at scalability, and most importantly, look at the determinants of why, these places are having this, and then use that to design models that could actually work for those environments. But like I said, it could also be costly, because that would mean putting in structure, right? That would also mean, in some level, training people, figuring out who needs to get certain expertise to run certain things. And I want to bring you into weighing on this one, because it was really mind-boggling when I was reading it yesterday.
So yes, so instead of the whole metric is what can we do in scale, and like I said, if there's no ground infrastructure, think about what can you implement. What can you implement? Because this is a health equity thing. Sometimes people think health equity is based on race and ethnicity. No. Health equity is about intentionality. It
Mm.
is about what intervention are you creating that is removing a barrier or hindrance to care that can get that population to the same outcome as the majority or whatever the baseline group. So you can go in a group with no infrastructure, but then you immediately know there are many things you can fix. Is it first you get a screening facility? Do you get a coordinator, person that can educate about specifically biomarker testing? Sort of the world is your oyster, but it's just where is the funding going to come from? So this is where sometimes patient advocacy groups come in well, because sometimes government listens to patient stories.
Mm-hmm.
And if you can partner with things like American Cancer Society, their Cancer Action Network, or some of the larger orgs around the disease like longevity, where they have, a lot of historical policy, then you can, or even Illinois Lung Cancer Roundtable, they can then work within the state and legislature to try to bring the patient stories forward, because it's typically when you can relate it to something that impacts one of the funders or the government people, then it tends to have more likelihood of getting implemented. But policy is still always a slow lever, but it is necessary.
Thank you so much for that response. So, my follow-up question would now be, what is that uncomfortable trade-off that we need to do within system level in order for us to confront rural lung cancer equity?
Uncomfortable truth is that we need to just give more money to the places. We need more facilities. And we need to
Yes.
start putting a price tag on it, because once you put price tags on it, then you're putting price tags on people's lives. And that's not a point we should ever be at. But unfortunately, that's how a lot of care is delivered.
Thank you. But my next question would be, looking at, because this whole episode is about rethinking or reimagining how to finance rural health, right? And we have seen this trend. And to be sincere, this administration didn't start this trend. There's been a fatigue buildup of health financing mechanism for a couple of years now. It's just that we weren't paying so much attention until this administration came and it's like broke the camel's back or opened the Pandora box, and everyone get to see, those things that we don't want to see when we are using magnifying lenses to look at things, right? But now here we are. We are human beings. We pivot and we redirect. What would be that sustainable funding process that you would advise, or that you think that going forward, if we use that, it will not only fund outreaches and screening, but it will also help build trust, and also improve, the word that you used earlier, the act of precision medicine practices, in ways that get everyone to have potential access to care, irrespective of where they live.
I think a great mechanism that could be implemented, this is just one, is PCORI, Patient-Centered Outcomes Research Institute. They have periodic grant calls for looking at comparative effectiveness research. So you can compose a study where you could say, we want to look at these two approaches for increasing lung cancer screening in a rural community. It could be maybe you just do standard patient navigation. Maybe you do navigation and you bring in a doctor from a more major medical. This is just an example, but then you have a comparator arm, and then of course you also need to have patient engagement and involvement on the grant. That's the one thing that PCORI is really big about. You must have, representative patients and their lived stakeholder experience, and they have to be active parts of your grant and evaluation and then you get that in and get that funded, then you could do some great work. And Corey grants require the funders to report out all the results and report the results to the communities that have been involved in the study. So it is a good mechanism to set up something in an under-resourced area that could have lasting impact.
I like this approach. That's I think it also dovetailed to the conversation about participatory community-led processes, where you are not just doing research or intervention on the community, but the communities are also part of the process from like the beginning. And it looks at comparatively, I guess this, I'm just thinking out loud, and I already like this, and sincerely, I would go and look at this more because it seems like a very good model for interventions that get to, pocketed places that have been overlooked for a certain number of time to really drill down and see what is happening here and how can we help. So thank you very much for bringing that up. We will go for another quick break, and when we come back, we will be wrapping up the episode. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from researching to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. Welcome back. So, Dr. Eugene, I know that you've talked a little bit about the question that I'm going to ask you since we started having this conversation, but I want us to have a compact response for how we think we're going to move forward if we are really serious about cancer care, addressing cancer and lung cancer issues. If we are serious about this in financing lung cancer in rural communities, beyond short-term grants or pilot programs, what part of the system, and this is me looking holistically as a system, what part of the system would you say need the most urgent sustained investment?
I would say the area that needs the most sustained investment. There's a lot of things. I would say get navigators. Navigators. We need to have funding for navigators, because typically they had been the ones that do a lot of the work. And I think until maybe last year or two, they weren't even allowed to be, what's the word I'm looking for? You weren't allowed to directly bill them for time working on navigation. I think there was something in the last insurance bill, but now you can bill for navigation. And so there's now a path so that the hospital doesn't see it as lost revenue. So this is the way now the staff gets paid for the time, and the hospital can recuperate some of the expenses.
Thank you. And my other follow-up question is to have this done, in ways that are sustainable. Who do we think needs to come to the decision table?
I think to have this done at a broad scale, you need the healthcare systems, you need the insurance providers, you need the clinicians, and you need the patients all in the same space. And they all have to have equal weight and voice, and and listen to the barriers and challenges each is facing, and how you can collectively make a solution that works for all.
Thank you very much. And to our listeners, the question on who decides what is one that we will keep asking across this series. So while you listen, also feel free to chime in here. So Dr. Eugene, I think at this point, I would want to summarize my takeaway from this conversation. And you really hit something very important today about lung cancer care outcome, that these outcomes are quite shaped even before the patients come to the clinic, right? We've talked about trust, distance, funding. We also talk about and reflected on I think I like that most, the fact that you bring your lived experience to this, like as you navigate through the system and the way you talk. It shows that you are not just sitting in the, board chair and making decision. Like you experience this all across places where you've been to, you've walked in, and you've seen these things show up. So to me, it's reminding me, and I believe to the audience, that the real solution to all of this does not just reside with medicine. We need to create a system that actually works for people that are living in places, those places that you would have mentioned, that really does need this care the most. We should be able to map those places clearly and bring a direct intervention closer to them. But before we close out this episode, I wanted to ask you one last question. Despite all of these challenges that we have discussed, what gives you hope about the future of lung cancer care in rural and underserved communities?
I think the one thing that gives me hope is the fact that, like I said, lung cancer is driving precision medicine. Mm-hmm. So we're still now understanding more potential biomarkers and therapies that can impact care. I also want to mention, even though it may not it could direct impact rural, Northwestern University over there has a lung cancer transplant program. It's sort of your last leg, but it is a great clinical trial program for patients with lung cancer. Now, you have to do all this extra qualification, but it requires you to be, I think, on site for a year or so. But there's a great option when you are out of options. But that's, like I said, last resort.
Thank you so much. Thank you very much for that answer. And I agree with you. My only addition would be, as we have all of these big scientific discovery, there should be ways that we domesticate them in ways that makes them more accessible to people all around the countries. So, Dr. Manley, thank you so much for joining me today and for bringing such honest and humane conversation. Your work reminds us that equity must wear intentional heart for how health systems should be designed, funded, and trusted. I truly appreciate the way you bridge different perspectives with community voice, and I am grateful for the work you continue to do to make cancer care more accessible and just for communities that are often overlooked. To everyone that is listening, thank you for joining us on today's episode of What About Rural Health? If today's episode moved you, challenged you, or made you think a little differently, please follow, subscribe, and leave us a review on your favorite podcast platform. And as always, let us keep asking the question, what about rural health? Until next time, I'm still your host, Chinasa Imo. Bye for now.